Guys, Eyad here, and I'll be talking about CNS trauma today. Today we're going to be focusing on herniation and intracranial hemorrhage, both extracerebral and intracerebral. So brain herniation is displacement of brain tissue between skull openings or posterior folds. And I'm guessing you guys took already a presentation on intracranial pressure. Brain herniation is the most common presentation of increase in intracranial pressure as a consequence. And there are three major subtypes that you guys have to know. So one is subfalcine, the second is uncal or the transtentorial herniation, and the third would be the tonsillar herniation, which is the most life-threatening. I put it in order from less life-threatening to more life-threatening to the most life-threatening. The subfalcine herniation is the subfalcine gyrus, goes under the falx cerebri. So you guys remember from connective tissue holding the brain together, falx cerebri is superior, and once it herniates under it, it compresses the anterior cerebral artery, which causes focal cerebral ischemia, causing infarction. Least life-threatening so far. But the transtentorial herniation is when the uncus, the medial temporal lobe on the right or left, goes through the tentorium. So from there, it can compress four things. Still less life-threatening, but more life-threatening than subfalcine herniation. From there, it can block the oculomotor nerve, CNS3, and it causes deviated eye and dilated pupil unilateral to the herniation. Meanwhile, if it blocks the midbrain, it can cause a dural hemorrhage, and which is either epidural or subdural. And it can block the posterior cerebral artery, causing occipital lobe infarction, and from there, blindness. And then it can cause contralateral cerebral peduncle compression. So before that, after that, I mean, it causes dissociation in the pyramid, so it would cause ipsilateral hemiparesis. And then you have tonsillar herniation, which is the most life-threatening. So one of the cerebral tonsils goes through the foramen magnum, where the brainstem goes through, compressing the brainstem, and then from there it blocks the cardiorespiratory nucleus, causing cardiorespiratory arrest and then death. And that's why it is the most life-threatening. Now, brain hemorrhages, we define them as it's bleeding into any space in the cranium. Please don't get confused between intracranial hemorrhage and intracerebral hemorrhage, where intracerebral hemorrhage is a subtype of intracranial hemorrhage, but intracranial hemorrhage means bleeding in any space in the cranium, including the cerebrum or outside. Which comes to our second classification, which is the intracerebral hemorrhage, usually old people above 60-year-olds, and it's less common than extracerebral hemorrhage, which is rupture of small intraparenchymal vessels causing bleeding between cerebral tissue. And then extracerebral hemorrhage is rupture of meningeal vessels, so you guys can imagine that it happens between the meninges or between the meninges and the skull, but it doesn't happen between cerebral tissue. And there are subtypes that we will go over one by one, but I want you to look at the picture between intracerebral hemorrhage, as you can see, and then the three types of extracerebral hemorrhage. And as you can see, it doesn't cross the brain-blood barrier. So you guys took stroke as well. I just want you to know that ischemic stroke, which is because of atherosclerosis and ischemia, is not the same as hemorrhagic stroke on CT, where typically it appears as a decreased density on the CT scan, as you can see. But hemorrhagic stroke, because it's blood pooling, so the CT would be hyper intense. So thalamoganglionic hemorrhage, as the name suggests, is bleeding into basal ganglia and subsequently, not always, the thalami. So what we know is it will always involve the basal ganglia, but not always a thalamus. And it's a type of intracerebral hemorrhage. From anatomy, you guys know that branches of the circle of Willis, there is called the lenticulostriate arteries that pass through the thalamus, as well as the ventricles and the basal ganglia. And here, malignant hypertension, specifically malignant hypertension, can cause hyaline arteriosclerosis of the lenticulostriate vessels, which then it weakens and it causes something like a Charcot-Bouchard microaneurysm. And from what you guys remember is that there are two aneurysms most common in the brain, which is the berry aneurysm, But in berry aneurysm, in the case of rupture, it would cause subarachnoid hemorrhage, we will take later. But this one is the Charcot-Bouchard microaneurysm, very weak, easy ruptured, and then bleeding into basal ganglia and the thalami. And then lobar hemorrhage, as the name suggests, means microbleeding into one of the hemispheres, so one of the cerebral lobes, whether left or right. One is that it's mostly caused by the cerebral amyloid, but in other cases it can be a tumor or vascular malformation. And then if in the case of amyloid, it would deposit in vessels, cause, as you guys remember, fibrinous necrosis, which then weakens, same ruptures, but this case, it's bleeding into a part of the cerebrum and not the basal ganglia or the thalamus. And then the third type is a slit hemorrhage. A slit hemorrhage can appear on a CT or a biopsy most of the cases, but it's any type of hemorrhage, intercerebral hemorrhage, from a microbleeding, which then gets reabsorbed. So as you guys can imagine, the artery was bleeding at the beginning, but then once it gets reabsorbed, it just appears as a slit, and hence the name slit hemorrhage. So hypertension is the most common cause, but then rupture and then reabsorption and then slit. Now for the extracerebral hemorrhages, you have epidural, subdural, and subarachnoid. And as the name suggests, it really depends on dura mater and the arachnoid matter. But in all cases, it's extracerebral, which means it's intermeningeal, either between each of the meningeal layers or between a meningeal layer and the skull. So epidural, as the name suggests, it's above the dura. So you guys can imagine dura mater is the most proximal part, so it gets sandwiched between the skull and between dura mater. Now, one thing you have to know is that the difference between epidural hemorrhage and subdural hemorrhage, the most important part is that epidural is arterial. Meanwhile, subdural, which you can imagine because the sinuses pass subdurally into the arachnoid matter, is going to be venous. So, arterial accumulation of blood between dura and skull. The most common cause is temporal trauma. The reason for that is that the petrous part is very weak. As you guys can remember, the temporal bone has two parts. And as I said, the petrous part is very weak, easily ruptured against blunt trauma. So let's say someone gets smacked in the head, on the right head, and then you have rupture of the middle meningeal artery, which is, from anatomy, is branch of the maxillary artery. And then it causes very rapid accumulation of arterial blood, unlike in subdural hemorrhage, because venous blood will be slow accumulation. This causes a lens-shaped separation. As you guys can see in the picture of the CT, there's a lens shape or a biconvex shape between the dura and the skull. And you can also see the skull fracture in most cases on the CT or an X-ray. Now, there are two representations of it. If it is fastly expanding, the symptoms are going to appear but then permanently disappear. The reason for that is clotting. But if it's slow expanding, it doesn't have enough time to clot. So there will be a very, very important sign for it, which is the talk and die cycle. And it can happen for up to days, then weeks, then months, where someone is asymptomatic, normal, and then neurodegenerative symptoms out of nowhere or syncope. So you guys can imagine talk and die, where he would be talking normally, and then syncope, so die, and then he would wake up again like nothing happened. That is a very, very important characteristic of epidural hemorrhage. So, as I said before, subdural hemorrhage is due to venous accumulation between the two dural layers. So, in this case, it would be bridging vein, and the temporal bone doesn't have to be fractured in this case because, as I said before, the temporal bone is very weak, so it causes a risk of fracture of the arterial supply. But in this case, it is of venous supply, so it's very deep, so it can occur anywhere, not characteristic the temporal bone. Now, subdural hemorrhage, as I said, is venous accumulation of blood between the two dural layers, and then we define them as acute or chronic. So, how does it start? Blunt trauma causing rupture of bridging veins, and the bridging veins occur between sinuses and the arachnoid matter, and slowly but largely expanding crescent-shaped hematoma covering the cerebral shape. we took the convex or the lens shape in epidural, but in this case we're gonna have a crescent shape, as you can see in the picture. Now, the landmark for acute subdural hemorrhage would be a venous clot. The reason for that is that when it's chronic and you want to see it on a CT and define did it actually happen acutely or did it happen a long time ago, is that the venous clot, if it was chronic in that case, it would go through lysis and then you won't see it anymore, as you can see in the picture. So it either resolves, which is in most cases, or continues as chronic. Now, first 48 hours are usually asymptomatic, and then you would have increase in ICP and progressive neuroscience, so dizzy, headiness, maybe syncope. And then you can see a midline shift can occur on CT, so the midline of the brain can be shifted, where you can see the whole cerebrum shift because of blood compressing the brain and then causing it to deviate to the left or to the right. And in chronic, it can either be, which is the least common presentation, is continuation of acute, but it can be associated with the child abuse or shaken baby syndrome, which causes thinner bridging veins, so more susceptible to hemorrhage, or brain atrophy in a lot of cases. Now, what happens in chronic is that after the venous clot occurs in acute, the dural fibroblasts form granulation tissue in the second week. So as you can see in the first month, the lesion becomes isodense, not hyperdense anymore. And then month later, only a subdural membrane is present, so hyalinization, causing almost looking like brain tissue, but it's not. And it's usually the cause of vascular dementia, which is one of the main common types of demential diseases after Alzheimer's, etc. And for the third and final one, it would be subarachnoid hematoma, which is the most life-threatening, but the least common at the same time. So subarachnoid hemorrhage, arterial bleeding into the subarachnoid space, usually due to a barianeurysm. How does it start? So barianeurysm can be either idiopathic or associated with diseases, so either congenital diseases or somatic diseases. One main common cause is people with polycystic kidney disease. The adult type specifically usually come with also barianeurysms that can be diagnosed with a angiography of the brain, but in some cases Marfan syndrome as well. And then for the somatic one would be where we define it as idiopathic because we're not sure if it is really causing the barianeurysm, would be smoking, hypertension, and germinal matrix hemorrhage in neonates. So it causes a saccular barianeurysm, where as you can see in the picture, there is no tunica media in the circle of Willis. And then easily ruptured and the blood falls inferiorly. Inferiorly as in it is closest to the neck than to the top of the head. And then 50% die almost immediately after bleeding, and that's why I said it's the most life-threatening. And the other 50% have permanent neural deficits, so like vascular dementia, for example. People usually complain, and it's a very specific characteristic of subarachnoid hemorrhage, is the worst headache ever, and it's usually in the back of the head, which is the occipital lobe. And then it can cause blocked arachnoid villi, so it would cause obstructive hydrocephalus, which would increase the ICP and cause herniation. Thank you guys for listening. I know it was a very short presentation, but I'm happy that you benefited from it. And here are some resources that I use. So Pathoma Robbins, as well as I gave a link to my written notes for the topics. Thank you.